We're going to go to the second case now. So this is a 51-year-old man who presented with abdominal pain. The abdominal pain is 3 days duration, and it's the worst pain he had since this morning. So that's why he came in the evening. Started after lifting heavy weight. He works as a laborer in a garage. As background history is of MI, which was 3 months ago. He's Asian by ethnic background, and he got high cholesterol. The MI was treated with stent, and he was doing really well with it. Obs-wise, he was tachycardic, hypertensive, and obviously sweating. He was in obvious distress. His pain was really out of proportion to his clinical examination, but his abdomen was soft and extremely tender, and it appeared distended as well. Bowel sounds were present. His VBG, lactate was normal, and his pH was 7.45. His bloods, all bloods were normal, except that his ALT was 264. The rest of the bloods were normal. I would like to pause in here and just ask you guys, what would you do? So you have given the patient strong painkillers, the patient got better, and then after about an hour, the patient gets the second phase of the pain and he's complaining of severe pain again. What would you do? ECG, just for you guys, I know you guys would be interested in ECG, says ECG did not show any acute changes. I would like to see what you guys would do from here. What most common differentials you would be thinking about. And of course, question and answer, please, Sam, for the chat.
Mesenteric ischemia.
Okay, good.
Abdominal ultrasound check aorta.
Okay, good.
CT abdomen to look for hepatic vein thrombosis or retroperitoneal bleed.
Excellent. Yeah, well done. Yeah, that's what I wanted to hear out from you guys. So yeah, mesenteric ischemia and the hepatic or portal vein thrombosis. These are the most common missed. And if you do so there was a study which was done in Harvard as well, and where they asked the radiology residents on a scan which was performed, and it was showing the mild portal vein thrombosis. And believe me, it was 72% of the residents, which were the highest residents, they missed it as well, the radiology residents. So it's quite like a most common misdiagnosis, which patient basically comes later on and they present with the complication. So what we did was, because his ALT was 264 and he was having the pain, so like you said, I wanted to check out for aorta that it might not be aortic dissection or the ruptured abdominal in aortic aneurysm. But I also wanted to see that he might not have pain which is relating to the back, that he might not have other difference. So I looked at his gallbladder and I wanted to see his liver. And this is what the ultrasound I would like to show you guys. So can you see there is the portal vein is quite thrombosed. So that's the portal vein thrombosis. I'll show you the still images as well. So this is the still image where you could see the portal vein thrombosis, and you see this increased echogenicity in the portal vein territory. So that was a case of the portal vein thrombosis. We admitted the patient under their medicine and the further treatment. But the other patient I wanted to talk about is just on the similar note. This one was quite recent, but the other one which I treated was in 2019. And at that time, I wasn't trained in the ultrasound. So what we did was basically, because his ALT was raised and his pain was out of proportion to the clinical examination, and he wasn't settling in. And you might have noticed that how the lactate was normal in this case as well. So we did the CT abdomen and pelvis triple pairs with contrast. Luckily, the radiologist was quite a good friend of mine, and we did the triple pairs because we explained the patient conditions. And this was the CT of the patient. So some of you guys mentioned the hepatic vein thrombosis. You could see that the right hepatic vein, if you look at it in here, it's not taking the contrast. And that's because of the hepatic vein thrombosis. And the other thing which we mentioned in here, which I want you to see, is not only to pick up the hepatic vein, but if you look at the caudate lobe of the liver, it's hypertrophied as well. And whenever you see these two signs, it's always pathognomonic for the Budd-Chiari syndrome. And there have been literature reports of cases which have been produced by the trauma as well. So in this case, although the trauma was trivial, so yes, we wanted to rule out the abdominal aortic aneurysm. Yes, we wanted to rule out the mesenteric ischemia. Yes, we wanted to rule out the other abdominal pathologies. But one of the other things which we need to keep in mind is, although these cases are rare, but they're not that rare, because I would tell you, If we would have just continued with the treatment and said, okay, let's admit you on do the D-dimer would have been erased. And then, yeah, let's start you on the anticoagulation. This patient, if you just start him on the anticoagulation, would not work for you because, there is complete thrombosis. So what you need in these cases is the TIPS procedure. So this patient had a prolonged stay in the hospital, but because the next day his ALT were raised up from 210 to more than 5,000. And you could see that how nicely the TIPS procedure stented that hepatic vein with the portal vein. So you see that portal vein thrombosis, hepatic vein thrombosis. One of my biggest worry for this one is basically the abdominal compartment syndrome. So if you get the hepatic vein thrombosis or the portal vein thrombosis and you mistreat these patients, the risk is that there would be the bowel wall edema, and because of that, inside the abdominal compartment, the pressure will rise. And because of that pressure rise, you will get the multi-organ failure. And because of that multi-organ failure, as you know, that it's a compartment, and it wouldn't resolve until you treat the primary factor. So it was a really interesting case that we've seen two cases, one from the portal vein thrombosis and the second one from the hepatic vein thrombosis, which was basically the variant of it, and it was the Budd-Chiari syndrome. Luckily, the patient had successful outcome. Just on that note, I wanted to see, I always check for the IVC, and whenever I see a patient with either the portal vein or the external iliac vein thrombosis, I always look for the IVC. And you could see quite clearly in this case that there is a big thrombus in the IVC. And these patients, I wouldn't just start on the oral anticoagulation. I would have a word with the specialist because they need something urgent doing. I'm going to flip this over from the abdomen to the limbs. So this is a case which came recently in June, 89 years old male who presented with shortness of breath and right arm swelling. He was admitted under medicine 2 days ago for platelet infusion because he was diagnosed with the ITP, and he was advised to stop his edoxaban, which he was taking for his AF, and he was started on prednisolone for his ITP. His background history was of COPD and atrial fibrillation. His observations were heart rate 86. Of course, his heart rate was irregular. His blood pressure was 136 over 63. His tap refill time was 2 seconds. There was peripheral pitting edema on both his lower limbs. His temperature was 36.2. There was petechial rash, generally widespread, and his right shoulder was tender over the glenohumeral joint and humeral head. There was limited abduction and flexion, and because of that severe pain, he was appearing breathless because he was breathing really fast. He was neurovascularly intact. The distal pulses were palpable, and he was able to move his wrist. There was strong radial pulse, and there was no motor drift. And this is what we did the ultrasound by him. So I wanted to see, if you look at in here, as Mike showed you earlier on, so this is the sign of the edema, and there is some fluid in here as well, which will come up. This is the closer look. You see the closer look. Look at the edema that we are seeing in the right deltoid region. And now, one thing good about the ultrasound is basically whenever you are not sure whether this is a normal variant or this is abnormal variant, always compare it to the opposite side. So this is the left arm of the patient, and this is the right arm. And what I'm doing is I'm getting the longitudinal view of his deltoid. So if you look at it, this is the humeral bone, that's his deltoid. This is the humeral bone, and this is his deltoid on the left side. So if you look at it just from the bird eye view, you could see quite clearly, look at this deltoid and look at this deltoid. This is bigger. And the other thing which we could see in here is there is a fluid in here as well. So that told me right deltoid swelling, there is a fluid in the right deltoid. Patient is having severe pain, as well as along with the patient pain, he's having the swelling as well. And of course, this patient was recently treated. The clinical impression was that this patient got DVT because they stopped the edoxaban, and now 2 days down, he's coming in, and he also was complaining of the breathlessness, so they thought it's because of that. We did the echo. Echo-wise, I did not see any features of the right ventricular strain, although because of his COPD, he had the right ventricular dilatation, which was chronic, but there were no acute signs of the strain. So we're seeing that there is a deltoid abscess and there is a swelling in the deltoid, and my clinical impression was that this patient might be having deltoid abscess, or this patient is developing the compartment syndrome, because of which he's having severe pain. These were his bloods. His HB was 76 before, and today it was 80. His white cell count was 22.71. His platelets were 51, which increased from 46. So luckily the prednisolones were working. as neutrophils were 20.61, and as clotting studies, INR 1.2 and APTT 0.7. It's not massively deranged. This is what the orthopedics did, and the orthopedics took him to the for MRI, and they did the MRI, and you could clearly appreciate this is the normal deltoid, and you could see the fluid in here. This is the second case, and that's the normal deltoid, and you could see the fluid in here. So that's the sagittal. I'll show you the, and if you see in here, there is quite a well-marked demarcation in here. So it's extending into the subscapularis muscle as well on the right side. Hence why the patient was having limited abduction, and he was thinking that the pain is coming from his shoulder. But you could see quite nicely that how is it extending into the subscapularis muscle as well. And this is the coronal, and you could see quite clearly how the abscess is there and the well-demarcated point. So look at this fluid and look at this fluid. So this is what it shows, that there is a debris in here as well. So the patient pain got worse later on, and then they have taken him to theater, and the patient had fasciotomy on drained the abscess. And after the drainage, they found it out it was a staph aureus which caused the abscess in this patient. Just on that note, I wanted to show you something else, and this is basically, especially in the context of legs. So whenever you see this thing, some people call it a cobblestone appearance. It's more common in cellulitis, lymphedema, and distal leg swelling. But whenever you see this thing, you always need to track it down that where it's coming from. And in this patient, I'll show it to you in here. So this is where it was coming from, and it's present in the right gastrocnemius, and that's basically whenever you see anything in that region below where you scan for the popliteal vein, and if you just slightly come down the semimembranosus and the gastrocnemius, and you see this fluid, it's the popliteal or the POCUS. So this is the other common thing which we most commonly picked up in A&Es when we do the ultrasound. We see that there is the swelling, and that's basically the right popliteal or the POCUS cyst, which they announced it on. There's other differential which you could come across for the swelling in the legs as well. Sometimes they rupture as well. And if you see the rupture, this is the other still images of it. And this is the popliteal vein, which you could see the nice flow in it, which could confirm you that it's not a DVT. So the emphasis of this case was that, sometimes the patient comes in with the presentation, and this patient was clearly labeled as DVT because of his right arm swelling, recently stopped the oral anticoagulants. It turned out to be a completely different problem. So I want you to keep it in the back of your mind whenever you come across these patients to think about using your point of care ultrasound. It's really easy, quick to learn, and quick to diagnose. And I think Michael would agree with me. If you get just a proper training, attend the ultrasound courses where they could teach you, I think you would save someone's life someday. So let's just go through about the typical signs and symptoms, which you all will be aware: the limb swelling, pain and tenderness, warmth and redness, which you've seen they were present in all of our cases. So the limitations of relying solely on your clinical presentation and just only the examination finding is that you would miss the time critical differential, which in these cases, like in my first case, was aortic dissection, and in our second case, you have seen that it was a compartment syndrome secondary to an abscess. So identify your red flags, look into the severity of the pain. If it's not responding to your thing, think outside the box. And remember, there is always role for history and examination that you need to risk stratify your patients. Conclusion. So we talked about the critical mimics of DVT. So we have seen the younger population, we have seen the adult population, and we have seen the pregnant population as well, which I would recommend that you keep them in the top of your bars. So if the and I think, Michael, we're not doing the popliteal entrapment syndrome, are we?
No.
Okay, yeah, that's okay. Yeah, so there would be part 2 of this webinar where we will go through the popliteal artery entrapment syndrome as well, because you may come across with the younger population who would have the classic features of the claudication, especially in that age group from 16 up to 30, where they are just becoming more athletic and stuff. And they get these symptoms, which would be in keeping with the popliteal artery entrapment syndrome. So they won't have the, the classic peripheral vascular disease, which would be the cause of it, but it would be this popliteal artery entrapment syndrome, which needs the treatment. I think there are 6 grades of it. So things like that, what you would need is basically the point of care ultrasound. So you've seen the mimics of the DVT. So we talked about the aortic dissection. We talked about the compartment syndrome. We talked about the popliteal artery aneurysm. And we have talked about the Maternus syndrome. So I want you to keep those differentials in your mind whenever you are coming across and whenever you are thinking about the DVT. So I think we're perfectly on time. We just finished the things. And I wanted you to, just for the quiz, I'm just going to tell you something, and then we'll go to question and answer. Can you differentiate whether this is pericardial or pleural effusion? So I'm just going to show you these videos. So as you could see, this is peristernal long axis view. So this is the left atrium, that's the left ventricle, that's the aorta, that's the right ventricular outflow tract, and this is something in here, which is a fluid. I think you all would agree with me. So is it pericardial effusion or is it pleural effusion? Let me show you the other view. You might want to see the Doppler. So I'll show you the Doppler through it as well. Okay. Okay, excellent. Anything else? So you could see that there is a ventricular wall rupture in here. And this ventricular wall rupture is responsible for the fluid to come into this space. And that was basically this patient had inferior STEMI about 6 months ago. And he came in with 6 months post-angio for a chest pain. And that's what it shows. So in order to know more about inside the heart, what the valves are doing, what the walls are doing, and all, we'll be doing our second webinar, which will be on 26th